Okay, dear colleagues.
Actually, Uli is
now Uli is there. I'm quite happy. So, dear colleagues, this is the second webinar of the vascular section of the EANS. I have a bit worried because Uli Zura was not available, and I fear that we have to cancel this meeting, but now I'm see him on the screen, so I'm very happy. I welcome you all for this webinar on cavernomas. You know that Professor Zura from Essen in Germany is an international renowned expert in cavernoma surgery, but also in cavernoma research. I'm quite happy that he is willing to give his talk on this topic. I'm waiting for it, Uli. And after your talk, which will last, I would say, 40-45 minutes, we have the chance you have the chance to answer some questions. I would propose that all the participants who have questions put it in the question and answer section and not into the chat. That makes it much easier for me to pick up and to select the questions and to allow Uli to answer some similar questions in one answer. Uli, it's your turn now. I'm happy that you can give your talk on cavernomas.
Thank you very much, Veit. Yes, I was a little bit delayed because, in fact, my time schedule set 5:30, but however, I'm here. Let's find now. First of all, I will try to share my my screen. Can you see my screen now?
Yes.
Okay. So Veit asked me to give this lecture on cavernoma and the experience that we have gained in the past, let's say, 2 decades. So in my clinic in Essen, we kind of developed a international or national CCM Cavernoma Referral Center. Our outpatient clinic has now more than 1,600. In fact, recently, I think it's more than 2,000 patients that we are following and that we are counseling. And since we did that for many years prospectively, we have a quite well-documented database. And you will see that by the various publications that came from our department concerning that particular topic. In my lecture, I will tell you something about the biology, possible drug treatments. I will make some points on the imaging. Of course, I will tell you something on the particular risk of hemorrhage, the indication for surgery, possible complications, and something about outcome and measurements. And I will give some recommendation. And finally, of course, I will summarize all the data. Within my lecture, which will last about 40 minutes, I will always give you some kind of short summaries, which are always highlighted a little bit in orange, like you can see on that slide. Now, let's start with the topic. Cavernomas are very well known to be able to grow. They may occur multiply. They can be radiation induced, particularly when people are radiated during infancy, for example, due to malignancy. They can also develop de novo. And there is certainly multiple form that we would find in families. So it's a familial form. Here you can see a typical pedigree of such a family. So cavernomas may grow. There may be multiple radiation-induced, de novo, and they can be familial. For the first time in 1999, and then in 2003 and 2005, there were 3 genes described for the families suffering from cavernomatosis of the brain. Nowadays, they are termed quite easily CCM1, CCM2, and CCM3. Here you can see a clinical case of a young boy that was operated early on, and some years later, his mother turned up with these 2 cavernomas that you can nicely see here. And she had another one, temporary mesial, that you can see here that I took out some years later. And this is a very typical pedigree, which is very special because the young chap was here, the mother is here, and you can see they had the grandfather that gave the gene to all his descendants. This is a quite very active tumor mutation or gene mutation that usually is given to the next generation in 50% of chance, but sometimes even higher. It's an autosomal dominant way to give it to the next generation. And if the people are suffering from a CCM1 lesion, some 20% of them would also suffer additionally from skin lesions, like shown here. Many years ago, we already discovered that there are also other reasons that, let's say, give rise to cavernomas, and this was described in 2008, as you can see here. And to explain what that means, I always like to show this this case, which originally came from Erfurt, and you can see here patient number 1, yeah, with a freshly bled cavernoma here, another one here, and there is a patient number 2 where you also can see some cavernomas here. And I will show you now the image of the cavernomas. Is very special here is this monozygotic siblings. They are suffering from the they are both suffering from the same CCM1 lesion, but certainly, and they were always living in the same place, small town close to Erfurt, but they were developing different types of cavernomas, as you have seen. So that is meant by a kind of a second hit that is important for the development of these cavernomas. So for familiar cases, CCM1, 2, and 3 genes are described. CCM1 is often associated with skin lesions, and a second hit also plays a role. I will now skip quite fastly over the next coming slides, which is giving you some clue for the, let's say, biology of the lesions. We early described that cavernomas may grow and that various types of expression for neoangiogenesis can be shown in the lesion, within the lesions. We then started to do a number of cavernoma endothelial cell cultures, as you can see here. And we could show that the cavernoma cells seen here, for example, would behave completely different from normal endothelial cells here from human umbilical vein endothelial cells, because these lesions are really sprouting and branching. And in cell culture, you can nicely see that here. If you compare that to a normal endothelial cell, it looks quite different. So a number of genetic changes have been described for the endothelial cell of a cavernoma. And it was well shown that cavernoma endothelial cells definitely grow, and they show neoangiogenesis. And particularly the 3 genes that I showed to you before, they play also quite highly active role. You can see that here, once we have a cavernoma cell and we knock out the CCM1, 2, and 3 gene here, you can see how the cells then start sprouting. So we can induce the migration, the proliferation, and the sprouting of these lesions once we knock out one of these 3 genes. So there is also described that in the CCM3 mutations, these patients might have a clinical more aggressive course. In our own patients, we cannot confirm this data, but it has been described. We published together with the Heidelberg group, with Helmut Augustin, we published a very nice paper on the endothelial cells that were silenced. Here you can see here non-silenced CCM1 cell, and here you can see the silenced one, which three-dimensionally starts to sprout. We collected that and put the endothelial cells under the skin of nude mice, and we could definitely see how the silenced cells compared to controls were heavily growing. So the good thing that we next did was we put in a tyrosine kinase inhibitor in the mouse intravenously, and we could induce shrinking of the lesions. That gave quite a lot of, let's say, hope to patients, and there were several groups thinking of using that clinically. However, it's not too easy to administer that drug in a, let's say, patient suffering from a cavernoma, because usually, of course, these people do not suffer of cancer, and there would be quite a number of side effects if you would give that drugs to a patient. So CCM3 gene mutations might be more aggressive. Mutations in one of the genes enhance the growth and sprouting, and the treatment is possible by tyrosine kinase inhibitor, but so far has not come to a clinical importance. One more slide, which is showing another thing that we by chance found. Also, CCM3 is a possible novel tumor suppressor gene when talking about glioblastoma. We published a number of papers on that as well. So here, this gene seems to play a role in the neoangiogenesis of glioblastomas. And there were a number of very nice collaborations with other groups that were published quite highly. Here, one in the zebrafish with a group from Berlin, as you can see, with a so-called cripple-like factor 2 and 4, which also have been nicely described to play an important role for the development of cavernomas. There was also a strong discussion and many papers on the possible effect of propranolol, so a beta blocker, for the treatment of progressive multiple cerebral cavernomas. Here we described the patient that we found that we published together with the Freiburg group. And you can see here the number of hemorrhages that became less and less by administration of propranolol. Also, other groups with well-known people have published similar case reports. However, also the administration of beta blocker is not yet brought to clinical routine, and there is nothing really other than case reports and retrospective studies. So far, there is no prospective study enrolled. The Americans tried that several years, but were not funded so far. So cripple-like factor is important, and drug treatment, well, we do not really know. The next very big hit publication we then did in last year. Also, this is a retrospective study with a high number of patients from several groups, where we retrospectively looked at, and we could find a very interesting effect. We looked at patients who received aspirin by other reasons, and the rate of hemorrhages of these patients. So these were the patients with aspirin, nearly no hemorrhage, and these were the patients without aspirin. Quite a high number of hemorrhage in comparison. So we could say, at least retrospectively, the antithrombotic therapy with aspirin might play a role. However, also we would not administer aspirin in our patients so far. This study was mainly done with a Scottish group with Rasim Al-Shai Salman, and he's now starting a prospective trial in the in England, in Great Britain, to see whether the administration of aspirin really would help. Here's also let's say plot showing you the significance of aspirin manifestation. So aspirin might help. I believe most likely due to the prevention of thrombosis in the caverns, and prospective studies on the way in Great Britain right now. Next topic is the imaging, and I was very happy because in Essen we have that 7 Tesla unit, and early on we started many years ago to look at Cavernoma patients in 7 Tesla. Why we did that is shown here, particularly the SWI sequence in very ultra high field MRIs shows very nice venous anatomy. Here's a close-up of a human brain that nicely shows you the venous vessels. So we could nicely show that the SWI imaging is very, very effective to demonstrate the cavernomas. You will see now a number of cases. We looked at many patients, and we could see cavernomas very clearly here, and we could distinguish several types of lesions. You can see here one cavernoma with one very small draining vein. Here's a cavernoma with several small draining veins, and here's a cavernoma with a so-called developmental venous anomaly. So this developmental medusa head-like venous anomaly we would find in approximately 30% of the cases, and in nearly all of the others we would find what we call a venous atypia. And this is true if we speak about single cavernomas and not multiple cavernomas. So this, of course, was also published a number of years ago. 30% of the cases with DVA, and the rest of the cases usually with a small venous atypia. And those of you who operated on a cavernoma, they very well know that there are small vessels that might have a contact to the cavernoma that need to be dissected and coagulated, and then should be distributed, and then you can remove the cavernoma. But never, 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 ever coagulate a developmental venous anomaly. This will usually lead to a severe venous infarction of the whole region. So as an X, we put more and more people in the 7 Tesla with multiple cavernomas, and you will see an image here where we clearly can acknowledge a typical DVA, and you see several cavernomas within these patients. This is a very special MRI form. We call that a typical cluster type MRI pattern of sporadic cavernomas, because we can see DVA here. In contrast to that, you can see here another patient with multiple cavernomas where you wouldn't see such a DVA. And this is either a radiated patient in infancy, as I explained before, or it's of a familial form, meaning that when a patient has not been irradiated in infancy and you see that, you can quite be sure, you can be absolutely sure in all our patients, we would find one of the 3 gene mutations. Whereas if you see a patient like this with a DVA and multiple cavernomas, you cannot find a gene mutation, and that in turn means that these results are consistent with the previous theory that venous anomalies, DVAs, are causative for the sporadic form of multiple cavernomas. So the MRI might even predict, or is able to predict, the CCM gene mutation if you stick to that rule in patients with multiple cavernomas. Now let's talk about risk of hemorrhage. So many years ago we published that article that nicely shows once a lesion has been bled, and if a lesion is localized in the brainstem, these lesions would have a higher bleeding rate than those not bled and those not localized in the brainstem. Recently later, there is also a meta-analysis that is showing the same thing. So once again, the highest risk are for brainstem lesions that have previously bled. And numbers here can go up as high as 60% per year per lesion. So from our large patient cohort, we did a number of studies. One was on the DVA. And in our very large number of patients, we could show that if the people are suffering from an associated DVA, they are a little lower risk to present with an intracerebral hemorrhage than those not suffering from an additional DVA. We also could show that particularly patients who, let's say, would have a higher body weight, are obese, they might have a higher rate for hemorrhage. And this is unpublished data, will be published soon in cooperation with a data set from Kelly Fleming from the US and also from the Dutch group of Ms. Surbier. And our data, here we showed that young ladies who would have oral contraception, that line would have a higher rate of hemorrhage than young ladies without oral contraception. So this is now under review. I think it will be published in 2 or 3 months, but it's also something that could be important when counseling patients. So contraception and obesity may increase hemorrhage risk. DVAs, additional DVAs do not. So the question, what to do? Once a treatment indication is established, should we do radiotherapy or surgery? There are still some people who are doing radiosurgery, and there are papers who are against it, and there are papers who are pro. In my opinion, and a lot of very prominent radiotherapeutic colleagues' opinion, this should not be done. You either perform surgery or you wait and see what happens, but you should not irradiate the lesions. From our data, we published also a paper, Philip Dammann did that, on kind of a classification system, showing you by a number of some items what are the more risky patients for bleeding and which are most difficult to dissect. We developed a kind of a score for that, and we distinguished 3 types. You can read that in Neurosurgery of 2017. This is to better be able to predict how easy a patient's individual risk for surgery is. Another very important topic when talking about cavernomas, of course, is epilepsy. This is a very, very frequent symptom of cavernoma. And we have looked at our data and also published that in between. And I can tell you it's quite easy. Because if you follow patients with that were operated and those that were not operated for a cavernoma, they would have, after 5 years, they would have the same morbidity. However, those who were operated, they would not have any more epilepsy. So that makes up a very clear indication for surgery if a patient is suffering from epilepsy and this epilepsy might be caused by a cavernoma. So, of course, you have a typical case. If you remove the cavernoma and it is possible and feasible, you should not only remove the cavernoma, but you should also remove the hemosiderin rim if this is possible and the patient is suffering from epilepsy. That gives usually very good outcome in these patients. Also, this was worked up by the International League Against Epilepsy, showing that cavernoma surgery is of very high benefit for people suffering from epilepsy. And the results, published that also a number of years ago, are even better after epilepsy surgery for Cavernoma when compared to hippocampal sclerosis. So there's an extremely strong indication for surgery when the patient is suffering from epilepsy. And if any possible, you should then remove hemosiderin when suitable. Now let's become a little bit more surgical. Here you would see a 19-year-old young girl who had 4 hemorrhages within 1 week. And she came at our clinic with this lesion. She was hemiplegic and completely aphasic. This is some MRI of her. And you could think, well, what to do? Of course, take it out, but how to take it out? Would you go that way? It's a left-sided one, maybe not such a good idea. You would subtemporal much too high. Through the Sylvian fissure, well, you know, very difficult to dissect, I think. From behind, also, you know, a lot of thalamus in the way. So, well, I decided to come this way, contralateral, interhemispheric, transcallosal, transthalamic, and it went quite well. The patient was doing very fine. Immediately after surgery, she started talking, and she left our ward 10 days after the surgery on her feet. So she recovered quite well, and that is to show you that there, of course, are sometimes, let's say, a little bit unusual surgical approaches that can be used to resect such difficult cases. Here's another one. I think this is very straightforward. I think Veit would have done the same way. I did it from behind. I did an infratentorial, supratentorial, supracerebellar approach through the pineal region, and it's quite nice to remove it like that. However, real thalamic lesions are quite rare. I collected only 10 of them. Here's another one, quite forward case in the pineal region, and you can nicely see here in magnification. This is how it looked like in the surface, and that is when I've taken it out. You have a nice view into third ventricle. Another one now, also a little bit thalamic, but more midbrain. And here I did also supracerebellar approach, and you can nicely see here. This is where I entered, and you can see in millimeter. I like to always put millimeter like that in order to demonstrate this before and after surgery. Usually the patients are doing quite well and recover quite fastly. Here's another one, very difficult one. How would you approach that one? I can tell you one secret is, if any possible, do not approach through the fourth ventricle, because that might really give morbidity to the patients. If possible, and you can come from the side, from lateral side, you should do that. And in this case, I have chosen for a subtemporal transtentorial approach. Yeah, you incise the tent here. This is a fourth nerve. You be careful that you don't cut the tent with the fourth nerve in. You have to look where it comes into the tent, and then you just cut it behind. And then you can incise the pons usually quite well above the exit of the fifth nerve. So this is before and immediately after surgery. This patient was also doing very well after surgery. Now we're going down the brainstem a little bit. You can see here another one with a Cavernoma in the medulla oblongata. Usually these Cavernomas can quite nicely be removed. You can see here before and after. And I have another one. Look at that. No indication. Don't do it. Don't remove it. It's inside. But now it bled and came to the surface. Look here. It comes to the surface in the lower part. in the right lower part. So I open, do a, let's say, posterior part of the transcondylar approach. I open the cistern here, and then have a look at the medulla oblongata surface, and you can quite nicely see it. I have my special bipolar here, and then in size, and you can see the cavernoma. Some blood is coming out, and then within the past several years, I more and more started, okay, to coagulate, but to try to dissect the cavernoma and pull it. By slowly pulling cavernomas like this that had bled so many times, you might be able to remove then, look here, the hemorrhages, the different hemorrhages, the cavernoma from, let's say, in this, from the brainstem or even other places in the brain that might be deeply localized. I always like to put in some Gelita, as seen here, because that gives nice images postoperatively. This is a post-op image. The patient was doing very well after surgery and recovered very fastly. One level lower, there's a C1 one here. This is quite easy because on the surface, I couldn't keep the vein. In the end, I had to coagulate it, but the patient was also doing very well and left the hospital a couple of days after surgery. So if you do that type of, let's say, surgery for deep-seated brainstem or thalamic or insular cavernomas, it's all about the approach and very special instruments. You use low current in bipolar, and if possible in the brainstem, you use a lateral approach and avoid the false ventricle. And of course, particularly when you go through the false ventricle, you use monitoring to monitor the various important nuclei. Now let's start to talk about complications. This is something that looks very straightforward. There's a pontine hemorrhage like that. This is a second hemorrhage after a short while after. When I went in and removed the cavernoma here, you can see my approach. This is 6 months after resection of the cavernoma. I don't know if one of you has seen that. What is it? This is 12 months after resection. It looks like a low-grade glioma here, doesn't it? I can tell you what it is. We know that from our stroke guys. It's a problem in the so-called Guillain-Moiré triangle. And this gives a very severe disability for the patients, very severe. The patients are suffering a severe palatal tremor, a dentato-rubral tremor, which is extremely disabling, and the ocular myoclonus. These people are really in a very, very, very bad situation. So we started up and collected some of the cases, and that was published I think in March of 21 in Journal of Neurosurgery. We call the tremor a Holmes tremor, and that is a very rare but extremely severe complication after resection of brainstem cavernomas. Yeah, you see a number of quite famous surgeons collected all the cases, and all of us, we had some. So this is called the hypertrophic Oliveri degeneration, and the Milano group, Marco Censato, initiated that type of research and wrote wonderful papers. So those of you who are interested in brainstem surgery should have a look at it. Now, if we talk about brainstem, there's a large meta-analysis published many years ago telling us that there is a long-term harm of surgery in 15% of the patients. So these were on numbers from the Essen series that I wanted to show you. From 837 non-brainstem cases, we operated 250, so 30%. But we were a lot more aggressive for, at that time, 200 cases, 43%. because of course we know brainstem and those who bled are more aggressive. So we are more aggressive in treatment of them. These are our recent data. Last time that we looked at that was in February of this year. And we are now following more than 250 cases, and we operated a little bit more than 110 of them, still 43%. So these were the numbers at that time. Most of the cavernomas are somehow linked to the pons. So mesencephalon is rarer, and medulla oblongata is quite very rare. I showed you 2 cases. And we also looked at our outcome. And here you can see something that is quite important. The average time for return to work in all the patients that we treated and that we followed was nearly 9 months. So that shows that these people usually are quite disabled. And one other very important figure is this one. More than 90% would do surgery again, although some of them were, let's say, had a morbidity after surgery, because many of them experienced several hemorrhages and really experienced hard times before the cavernoma has been taken. We also validated the Lawton-Garcia and our own score that I showed you before. And for brainstem cavernous malformation surgery. And we can tell you that best is to combine both of the 2 scores to estimate the later neurological outcome. So our most recent step that I'm very proud of is we performed Delphi consensus on the surgical treatment of brainstem cavernous malformations. And you would see here the same very famous guys who took part of it. We asked all these surgeons with large series what they would think should be done in certain cases. And we looked at that with statistics, and we then found out some things that have to be done, and we made a lot of let's say important suggestions what should be done and what is supported by this let's say experts opinion. So the Delphi consensus supports the decision making in future if you should do surgery for these patients or not, and it will be published maybe in October or November of Journal of Neurosurgery's issue. We also, if you're interested in the outcome assessment after surgery, we suggested some data on the health-related quality of life after that surgery that can be well taken if you want to compare your own results. So these are basically the 2 publications here. And this later publication is also interesting because we could show that patients with the diagnosis of cavernoma showed a decreased quality of life compared to the normal population, even when not suffering functional impairment or neurological symptoms. And that is something that we know from counseling the patients. Once people know, for example, by MRI due to a headache history, that they would have a cavernoma, they would have a definitely decreased quality of life. And that is nicely shown also in that publication. So this is one of my last slides. Here you see a 7 Tesla of one of our patients that has a very rare situation. This is a hemicavernovatosis of the brain, which is a mosaic of the right brain part, the right hemisphere. So the patient would not suffer of cavernosis in the other hemisphere. And I always like to show that image to make one thing very clear. If you see a patient like that, and the patient has no clear-cut neurological deficit from one of these cavernomas, you don't touch it. There is no reason to operate any of these lesions, and be very reluctant, particularly in patients who are suffering from multiple cavernomas, because we as neurosurgeons, we will never be able to cure these patients. You should only remove cavernomas in patients with multiple cavernomas when they are symptomatic, and when they are highly symptomatic and maybe the symptomatology doesn't change within a couple of weeks. So I summarize. Concerning the biology, I showed you that cavernomas might be acquired lesions. They undergo angiogenesis. There are 3 genes playing a role in the familial form. Cripple-like factor 2 and 4 seem to be very important during development. And there might be future treatment options by drugs, aspirin, beta blocker. There are other things on the way, I can tell you. Imaging diagnosis is best made by SWI or T2 star images. In sporadic cases, single cavernoma cases, we would find a venous anomaly in 70% and a DVA in 30%. In multiple cavernomas, there is a sporadic and the cluster type, sporadic with DVA, please remember, cluster type without DVA. Hemorrhage rate is reduced, most likely by aspirin, and maybe also by beta blocker. There is a higher risk for hemorrhage in previous hemorrhaged patients, and deep-seated localization and obesity and contraception might have an influence on a higher rate of hemorrhage as well. DVA might not have an influence. How to treat? The treatment of choice, in my belief, is surgery or wait and see. We should always counterbalance the risk, the surgical risk versus the risk of conservative management. Epilepsy is a very good indication for surgery in sporadic cavernomas. When talking about deep-seated insular and thalamic brainstem, it's a good indication. However, you need some experience to remove the lesions, and it's sometimes not so very easy, straightforward as it looks like. And if you want to have a deeper look in Brainstem, have a look at the publication in Journal of Neurosurgery coming on the Delphi consensus. That might help to guide you to make a decision which one to operate and which one better to leave. When we are talking about multiple cavernomas, be careful, usually should be reluctant to remove these lesions. So I thank you very much for your interest in that topic. Of course, all the data is mainly done and collected by my collaborators. The most important one of those, Philip Dammer, my associate professor, and Yuan Zhu, who is leading my molecular neurosurgical lab, and some other collaborators that you can see here. And quite funnily, I must tell you, I gave that lecture in Barrow rounds a couple of months ago, and I told my friend Michael, he wrote already some books on 7 aneurysms, 7 bypasses, 7 AVMs, and I told him, please, Michael, you go ahead and write a book on 7 CCMs. And he told me, okay, don't be afraid, the book is on the way. And he will publish that book in the end of 2021. So I didn't see it yet, but I'm quite sure that will also be a very nice book of Michael Lawton again. Thank you for your interest in the topic. I'm finished.
Yes, dear Uli, thank you very much for this nice, interesting talk on the, I would say, the whole field of cerebral cavernomas. There are a few questions as well in the chat, as well in the F&A section, so I would go through it. Just start with the F&A part. So there was one question which you already has answered in parts. I will read the question. What is the place of awake mapping and monitoring of motor, language, and other cognitive function in removal of cavernomas in supratentorial eloquent areas?
Yeah, it's very obvious. No matter, I mean, we do that for cavernoma as for any other lesion that is eloquent. Yeah, so that is not special for cavernomas. We do it.
Okay. Yes. Do you use often awake surgery in cavernoma cases? We usually use it in tumor cases, rarely in cavernomas, because they're well defined lesions, mostly easy to find.
I would use it when the cavernoma is very clear cut, close to Broca or Wernicke, and when the patient is already suffering some, let's say, impairment of speech. But honestly, of course, I operate quite a lot of cases. I can remember 2 or 3 cases more. There were not more than that. If I'm quite sure that it's close, I wouldn't do it, because, as you say, usually you can dissect it and you will not harm any brain tissue when you take it out.
Okay, thank you. So there's one question from Hamid Al-Sanusi. We thank you for the nice talk, and he would like to ask about the possibility of any endovascular intervention in very difficult cases or cases in which you think there could not be operated.
There is no place for intervention, because you would not even be able to see cavernomas in the angiography. If you perform an angiography, even in very large cavernomas, you have to wait quite a while if you might see a very slow blush, but it's impossible to do intervention for that. You might think of, let's say, a direct puncture, but for what? Because it's quite easy to dissect the cavernoma. There is no high blood pressure on it. So I think there's absolutely no indication for intervention. I never did it, and it was never necessary.
There's another question. First of all, I would like to propose to put all the questions in F&A section, not into the chat. It makes it much more difficult to read them all. Please use the F&A section, but now we are going through all the questions. There's a question: would you recommend to perform surgery after first epileptic seizure with evidence of hemorrhage on MRI?
That depends very much on age situation of the patient, and the question how severe the hemorrhage was. At least I would tell the patient that he has a quite high likelihood to have a second fit, surgical epileptic fit, and at least then usually patients would show up, and they would have a very good prognosis. I didn't show that. Epilepsy occurs very often when the cavernomas are, I mean, it's logical, but we have also shown that in detail, in data. When the cavernoma is localized in the temporal lobe, particularly in the temporal mesial lobe, which is somewhat obvious, and then second in the frontal lobe. But we have also, let's say, rarer epileptic situations in the parietal and the occipital lobe. And particularly, for example, when you have some kind of optical fits, it can be a very good idea to remove these lesions. And the patients, very often, they wouldn't even consider that this is part of the epilepsy. So you have to really nicely ask the patient and have a good history of them in order to counsel them to remove a cavernoma for, let's say, weird clinical situation, which is in fact in the end is epilepsy.
There are 2 questions which a bit belong together from 2 participants. The first is, do you recommend pre-op EEG in patients with cavernoma and MRI? And the other is linked to this question: do we need any additional workup, like video EEG, electrodes, in case of a single or very rare generalized seizures and supratentorial CCM without hemorrhage?
Okay, so it's a little bit again on epilepsy. So that has very much to do with the semiology of the epileptic fit. I mean, if the semiology fits to the localization of the Cavernoma, then it's quite nice. And of course, we would do EEG in epilepsy patients. In non-epileptic patients, we wouldn't do EEG. On the other hand, and yeah, that's basically the question, isn't it? Yeah.
Yes. Today I've seen a patient in my practice, and he has had a Cavernoma which bled. It was directly in the post-central gyrus, but there was the hemosiderin staining in the pre-central gyrus, and he presented with epilepsy. What would you recommend in this patient?
Take it out. We also published like 15 cases on that. Usually the outcome is very good, but in this case, of course, you leave the hemosiderin. But still, because it's eloquent cortex, of course, you leave the hemosiderin in the central, in the precentral, and take it out. The patient has a quite high likelihood to lose the epilepsy. So I guess the patient has motor fits on the contralateral side.
Yeah. So I'm quite happy. I gave the same advice.
Oh, this is a real clear-cut indication. Yeah.
Another question: do you have any experience with DTI for intratentorial CCMs? I guess yes. Yes,
we performed we perform them routinely, but let's say when I then finally choose the entrance into the brainstem, I still stick more to the quite well-known bundles and tracts. Yeah, and as I told you, there are certain places to enter the Cavernoma. You know, Spätzler once described the two-point method. So you see where the Cavernoma is coming to the surface, and let's say the farthest point apart from it. And in between, you can point where your approach should be, and that is where you do the skin incision and remove the bone. This is not always completely okay, in my opinion. We should really be very clear with the tracts. We know very well where the tracts are. And if you look for, let's say, upper midbrain mesial Cavernoma, you can maybe approach that with a contralateral pteronal approach and go through the midline from contralateral. But this patient, you will most likely give a permanent and forever third nerve palsy. And in my experience, it might be more wise to come from lateral and maybe even dissect, let's say 3 or 4 millimeters, and leave the interpedunclear cistern not attached. But you know, Spätzler has a quite nice series on that, and he also shows people who recovered from third nerve palsy. But I saw quite some people who didn't recover.
Okay. There was one question concerning immunotherapy. Can we immunologically target CCMs?
Yeah, there are several research. There are several research, not only proposals. There are even, to my knowledge, 2 companies, one in Italy and one in the United States, who have an immunological idea. And they are about to start finance clinical studies. I was contacted by them and interviewed. However, that was immediately before the COVID-19 story. So far, after that, I didn't hear anything of that. But there are, let's say, even some companies who try to push it. Yeah.
Could you please explain the idea behind which is targeted, or is it a secret from the company?
So I had to sign non-disclosure. I can't do that. But I must also tell you, they gave me some clue what they are hitting at, but of course they didn't uncover their entire research. Okay. And this type of research is based on some, yeah, let's say basic science research, even of what I have shown you. But in the end, they were not very clear what exactly they would, which part of, yeah, let's say key they would try to use. Yeah.
There is another question: why there's no place for radiotherapy?
Yeah, because if you know, it would be your own lecture, but I don't like radiotherapy because I had to operate on quite a number of patients who had radiotherapy, and to remove cavernomas after radiotherapy is even, let's say, more, maybe not more difficult, but more dangerous for the patient. So that's number one. And if you go and look closely to the publications will tell you the following. They say the reduction of the hemorrhage rate occurs after 2 years of the, let's say, the treatment. So that means they are happy with several hemorrhages within 2 years after radiation, and I don't like that. Yeah, I don't like that. If there is a cavernoma that, let's say, is difficult to and risky to operate, you know, some neurosurgical colleagues would then just send these patients to somebody who is not a real good and balanced, let's say, radiotherapist, and then they would do it because they would have the patient referred. If we talk to the, let's say, very very good and high standards radiotherapeutists in our country, in Germany, they wouldn't do it. They would not irradiate cavernomas.
Okay, there was a question from Sergio Buzic. I think it's going into the same direction, and your answer also would be no. Is there a place for stereotactic radiosurgery in adequate regions?
No, radiotherapy is radiotherapy, okay. And I wouldn't do it. I wouldn't do it.
Then it's very clear now. Is a DVA seen in 1.5 and 3 Tesla MRI scans?
Yeah, it's absolutely, you can see that 7 Tesla, or let's say ultra high field Tesla, is also, let's say, of research interest. And it shows one thing very, very nicely. If you have a patient with a cavernoma, with multiple cavernomas, and you put this patient in a 1.5 Tesla scanner, you would, let's say, find 10 cavernomas. You put them in a 3 Tesla, you find 20. And if you put it in a 7 Tesla, you find 40 in the same patient at the same time. So the higher the field strength, the more cavernomas will be found, and that clearly shows what I told you. It doesn't make sense to think of removing cavernomas in multiple in these patients. Leave them, and only when there is a severe bleeding of one of the cavernoma that gives symptomatology and neurological deficit, then you remove it.
I think this is a difficult question. Is the natural history of hemorrhage different if the cavernoma is de novo or is following irradiation?
We can't answer that question, but I can tell you all the kids that are irradiated due to a leukemia, we looked that up in our population. We have here a very large kids program in our hospital and a lot of patients. No matter which patient you take, 2 years after treatment, so whole brain radiation for leukemia, for example, all these patients, everybody will develop cavernoma. Or let's say small hemorrhage looking like cavernoma, and some have to be operated when they become clinically relevant. And I did it several times, but they will all develop it. So that is not spectacular. You leave them, and most of them would never have clinical problems. There are so many people irradiated in infancy that develop cavernomas without a problem. And by the way, the second most common pathology that occurs after irradiation is meningioma. Yeah, so the patients develop cavernomas after 2 years, and 10, 15 years later, cavernomas, and in the same patients, then meningiomas. We have quite a number of such patients collected.
One question which is coming in every talk on cavernomas, the question of timing for surgery. First timing from first fit to surgery, and the other timing from hemorrhage to surgery.
So as I told you, we are very aggressive for epilepsy cases. We offer surgery, let's say, very straight on for these patients. And in patients with, let's say, deeply situated and difficult approach and so on, large lesions, it's yeah, there's a place for discussion for that. I like to wait for, let's say, 2 to 4 weeks until the blood is a little bit liquid, because when you open the cavernoma shrinks and you will have some space to manipulate. But honestly, if we look at, for example, brainstem cavernomas, there is about 10 to 15% of the cases that would have what I call cluster type of bleeding. I had a patient last week. She came here, was treated elsewhere, and then she came here, and I told her, she was in a quite good state. I told her, maybe let's wait another week before we take it out. And she bled when she was hospitalized here in 2 days, 3 times. Enormous brainstem hemorrhages, and she was nearly dead. So, I mean, you really have to go in there. So be aware of that. If you send away a patient with a brainstem hemorrhage, you tell them, if there is something that happens, you must go in immediately and come back, please. This is 10 to 15% of the cases. And in the others, it might be easier and better to wait.
Okay. Uli, do you have seen a general difference between surgery of pediatric and adult cavernoma? This was a question from Miroslav from Zagreb.
Hi, Miro.
No, not the other, another Miro.
Okay. Because I met Miro from Zagreb last weekend.
Yeah, I think there must be 2 Miros in Zagreb.
Hello, other Miro. No, the thing, there is one thing on pediatric. Pediatric cavernomas might be very large, extremely large, but usually they are quite nicely to dissect and no problem to take out. However, there's a very rare sub-entity of pediatric cavernomas. I saw that maybe 2 or 3 times, that kind of have a let's say, infiltrating way of growth. They would kind of invade a sulcus. Yeah, they grow in the brain and then they invade a sulcus, and they are not not only let's say a plain tumor or a plain cavernoma, but they also would have like branching parts, and you must be very, very careful to dissect them, because it's extremely important, particularly in these cases, to completely remove the cavernoma. It's always completely important, because surgery makes no sense when you do not completely remove it. The patient will rebleed. Okay, so I have an eye on the time. There's one question. In case of a small brainstem cavernoma that blood produced symptoms, is it possible to consider observation? Yeah, in any case, if the symptoms improve? Yeah, absolutely. With the first hemorrhage, we tell the patient what is the risk to remove it, but we also would tell them that there's a possibility to wait and see, particularly when the symptoms resolve slowly, and that they should come back when, let's say, the symptoms start again. And I showed you this number of more than 90% who would do surgery again. And that is one of the reasons, because we wouldn't immediately go in. The patients would have experienced, or usually at least twice, a hemorrhage. And therefore, you know, even the patient feels more comfortable after surgery when he or she would kind of keep a neurological deficit. However, in our hands, I must say, we would have less than 10% of patients with a severe deficit after surgery. We had one patient now that died after surgery. So that is, yeah, these are the numbers.
Okay. There's one question from Marwa Najar. He wrote that he usually performs intra-op echoes during surgery for Cavernoma with epilepsy. Do you agree?
Yeah, you can do that. I did it many years ago. More recently, I don't do it any longer because I simply removed the Cavernoma and the hemosiderine, and the outcome is excellent. But in the beginning, I did it, and sometimes I removed even a little bit more of the cortex, but still our outcome is so good. And it's you know, expensive. You need the strips for echoes. We don't do it any longer to save money and time.
Okay, so there are some questions which are, I think, already answered. There's one. Uli, could you give us a percentage of the cases where the epileptic seizures settled in your department? So
resolved,
seizure-free after surgery?
I must have to read it up in the paper of Philip. You can look it up in Journal of Neurosurgery. I would say 90%.
90%.
But please read it. I don't have the exact number now. Yeah, it's published.
Okay, that's an interesting question. Do you advise patients with a first-time bleeding to formulate an advanced directive medical proxy, Patientenverfügung?
No.
Okay. So
I mean, it depends where the I mean, if it's in the center of medulla oblongata, maybe yes.
Okay. So now I switch. I think this had been all the questions in the F&A section. Some are a bit similar, so I put them together. And now I switch to the chat just to check if there are some new aspects. Incidence of rebleed in cavernomas in general.
Risk of hemorrhage. Well, we say something from 1% to 60%, depending on localization and if they have hemorrhage before. 60% in brainstem and 1% maybe on right frontal, non-eloquent. Yeah.
Okay. There are some greetings from Aberdeen. They're taking part of the CARE study.
Yes.
And I think this is
the CARE study. Let me comment. The CARE study is the Aspirin study, which is prospective now. But I must tell you a story on that. You know, when we published together, we published the paper. Some of the families that we are treating, you know, they have a lot of members and so on, and they read it and they came across it, and they immediately started to take the aspirin, aspirin 100 milligram. And in two of the families, there were no episodes for years, and there were large families. And in those two families, all the members who took the aspirin had several hemorrhages within the weeks after administration of aspirin. It's unbelievable.
Again, a question concerning a bit the beta blocker. So do we have any data about the effect of beta blocker concerning reduction of hemorrhage rate or reduction of
there are
all growth?
Yeah, they are all retrospective. For example, the Bern group, they published a nice retrospective study suggesting that that might have a role. That, by the way, that came from the small kids which have the facial angiomas, and you administer propranolol or a beta blocker, and they diminish. So this was the initial idea, to use beta blocker, but there is no prospective study, and there are a lot of concerns. The Americans, many years ago already, they were trying to perform a study, multi-center prospective study, but they had no funding from the FDA.
Okay. And I think this is the last question. It is asked, or there was a case of bleeding in the cerebellum after a high velocity crash. And the question is if you see some sort of association between high intrathoracic pressure and Cavernoma associated bleeding.
No.
Okay.
When I should tell you what I believe a Cavernoma is, this is a thrombosis. This is a thrombosis. In the beginning, it's a thrombosis. And that is why in some of the patients, aspirin works, because it prevents thrombosis. And no thrombosis, no bleeding. But there is, of course, there are several theories and several pathomechanic explanations how things happen. One thing that is quite true is when you have a, let's say, high velocity trauma, you might have mini hemorrhages that in MRI after a while, they might be very similar to look like Cavernoma. So for that reason, you must look nicely look if there's like the typical berry-like Cavernoma in the MRI in the center. Otherwise, it might be the residual of a high velocity trauma. Not so rare.
Okay, so we have had a very nice discussion round at the end of your beautiful talk, Uli. I think all the participants listening to the talk and discussing with us, I think the peak number of participants had been around 185. I think this is very good from all over the world. So the webinars of the ENS are attractive, I believe. And today we've seen why they are attractive. You're getting a lot of information. I thank you all, you especially, Uli, for your nice talk. And many of the participants also had said that they have been quite happy with our presentation. Thank you.
It's
Bye-bye.
my pleasure. See you others for another event, hopefully personally.
Yes.
Okay,
Bye-bye. Bye.